My name is Michal Steinberg. I'm a pulmonologist or lung doctor from Haifa, Israel, and I'm a member of EMBARC, the European Bronchiectasis Collaboration of Clinicians and Researchers. And we have an international audience, and for that, before I start, I would like to draw your attention to the automatic translation option. You can find the link in the chat, and when you click the link, it will direct you to an automatic translation option where you just have to choose your language, and you will see alongside the conference, you'll see the translation in your language, written translation in your language. This patient conference is in its second year and is now becoming a tradition. The conference was organized as a collaboration between the European Lung Foundation and EMBARC, which is the clinician and researcher bronchiectasis collaboration. And we thank very much the members of the ELF Bronchiectasis Patient Advisory Group who organized this according to the wishes and requests of patients. And the content of this conference was made according to that. And we thank the ELF and the Patient Advisory Group and all of the people who helped to coordinate this conference. Can I have the next slide, please? So this is the ELF Patient Advisory Group, and some of us are planning this conference today. I'm told that it's Mother's Day in the UK, so accordingly, we're all women here today in the planning group. But of course, we have both sexes in the speakers and of the audience, of course. The audience is made up mostly of people with bronchiectasis and carers and family members, but we welcome also healthcare professionals and researchers who are joining us, wanting to find out more about bronchiectasis. So with that, I will hand over to my co-host, Ano Kuusisto.
Thank you. So hello everyone and welcome to our second bronchiectasis patient conference. My name is Anu Kuusisto and I'll be co-hosting together with Dr. Michal Steinberg. I am from Finland, but I live in Denmark. Hence there's a mention of both countries next to my name. And I joined the European Lung Foundation Patient Advisory Group, or PAG as we call it, in July 2021. So I'm still relatively new to the group. I was diagnosed with bronchiectasis in November 2020, and I've also had mild asthma since childhood, which made it a bit harder to reach the diagnosis for bronchiectasis as some of the symptoms can be common. And in the end, it actually took about 7 years. When it comes to treating bronchiectasis, there's no one-size-fits-all treatment, and each case needs their own treatment plan. Self-management and treatment play a big part in managing our condition, and therefore we wanted this year's conference to focus on those topics. Although we covered some of that already in the first conference last year, this year we will have more patients sharing their own experiences, how they manage. We hope some of the experiences and tips shared will give insight to the different ways of managing bronchiectasis. We also wanted to highlight the fact that although statistics show that a large majority of bronchiectasis patients are age 60 and above, there are patients in every age group out there in different stages of their lives. Paulina, could you please show the slide? You can see in the next slide some statistics on who's attending our conference today and from how many countries. I don't know if Paulina has put that there yet. Yes. We encourage you to engage and be interactive in the chat. You can say hello and tell us where you are from. In case you have any questions, you can put those into the Q&A box. You also have the option of asking your questions anonymously by clicking on the box at the bottom of the Q&A window. And there's no such a thing as stupid questions, so please keep the questions coming. There's a team of people who will be answering as many questions as they can throughout the day. Please do keep in mind, though, that we cannot answer questions about anyone's personal circumstances or case. Please like any questions in the Q&A that you most want answered by using the thumbs up icon, as this will flag them for attention and may help to avoid the duplication of some of the questions. And now just a bit about the outline of the sessions for the day. You can access the program also on the ELF website. I will put the link into the chat. There's going to be 4 main sessions, and each has 2 co-chairs, a patient and a clinician. They will introduce the speakers, keep track of time, and coordinate questions to ask at the end of the session. There's time allocated for questions after each session, so please write your questions in the Q&A box at the bottom of the screen as we go along. The first session is on the basics of bronchiectasis, as it's important for us to understand what it is and how it can affect us. After a 15-minute break, the second session will cover treatment and self-management. We will then have a 1 hour for lunch before coming back for session 3 entitled Diving Deeper, which goes into more depth about the specific issues affecting people with bronchiectasis. For example, Pseudomonas, which is a common infection in bronchiectasis, and antibiotic use. The final session will cover new treatment and research. Michal, did you want to go through the housekeeping?
Yes, can we have the next slide, please? So some housekeeping comments. First, this is a webinar style event, so all of the audience is on mute and with no video. We can't hear or see you except for the speakers and chairs. But we do want you to be involved, and we'll have the chat options that you're already writing in. We have the questions and answers, and please write as many as you can. And we'll have polls that we'll see in a minute, practice in a minute. If you want to communicate in social media, please use the hashtag Bronchiectasis 2022 and the handles European Lung and Euro Respiratory Society and EMBARC network. The talks are recorded and they will be available to watch after the conference. So if you have to miss some of the conference or you want other people that you know to watch later, that will be possible. Can we have the first poll for practice? Yes, so the first poll is we're asking the audience how you learn about managing your lung condition, and you can choose as many options that that fit. Is it my doctor, another health professional like a nurse or a physiotherapist, written materials such as leaflets, patient groups or patient organizations, Facebook groups and other social media, or other, and you can please write in the chat. So we have 2 minutes. If you can please start voting now. So while people are voting, I'll remind that we have some polls throughout the conference, and it will be very interesting to hear the responses, see the responses of people. We're learning so much about bronchiectasis from the experiences of our patients and patients and caregivers. So if you can just a minute or so for voting. Okay. So can we see the results? Yes, perfect. So I learned about managing my lung condition from, most of you said, my doctor, 49% another healthcare professional such as nurse or physiotherapist, 36% from patient groups and patient organizations, and then written material, Facebook groups, and other. And so we really hope that this conference today will be another resource that people can use later to learn more about bronchiectasis and self-management. Anu, would you like to
Yes.
present the chairs?
Yes, so it gives me great pleasure now to introduce the first session, which is on the basics of bronchiectasis and will be chaired by Annette, Posthumus, and Professor Stefano Aliberti.
Morning, everybody. My name is Annette Posthumus from the Netherlands. I'm a member of EMBARC since a long time already. And I would like to introduce Professor Aliberti to you.
Good morning, everyone. It's a pleasure for me to be here with all of you, and this will be a great bronchiectasis patient conference. My name is Stefano Aliberti. I'm a professor of respiratory medicine at Humanitas University in Milan, and I'm a pulmonologist with a special interest in bronchiectasis. Together with Annette Posthumus, we will be chairing this great section on basics of bronchiectasis, where we have Dr. Amelia Shoemark giving us an overview on bronchiectasis. Professor Lucy Morgan from Australia will be focused a little bit more on the role of viral infections in bronchiectasis. And finally, my task will be to give you an helicopter view on the most important treatments we have today for this disease. And then we will have 20 minutes of questions and answers before the break. So it's my pleasure now to give the stage to Amelia Shoemark, who is a principal investigator at the School of Medicine in Dundee. Dr. Shoemark has a special interest in bronchiectasis and in genetic causes of bronchiectasis, especially primary ciliary dyskinesia. I'm happy, Amelia, to give the stage, and thank you for being with us this morning.
Thank you, Stefano. Can everyone see my slides all right?
Yes, we can.
Yeah, great, thank you. So yeah, I'm going to talk this morning just an overview of bronchiectasis and introduce some of the topics that we will be talking about throughout the day. So first of all, what is bronchiectasis? Bronchiectasis is a long-term lung condition in which the airways become widened and inflamed and contains excess sputum or mucus or phlegm. It's actually the third most common long-term lung condition behind asthma and COPD. And when I started working in bronchiectasis, people thought that maybe it would be a condition that would go away because of vaccinations against infections and treatments of conditions like tuberculosis. But actually, we now know that more and more people are getting bronchiectasis. It's becoming increasingly prevalent, or there are more people who suffer from it. And I've put some little graphs in the bottom corner of this slide. These are from a study in Germany, but there have been similar studies in the UK, just showing year on year people are getting bronchiectasis. So what are the symptoms? I feel a bit silly telling people who have bronchiectasis what the symptoms are, because you probably know, but most commonly people have a long-term cough, and often you cough up sputum or phlegm, and that can vary from person to person. So some people will have a very dry cough and just have more of a cough when they're feeling unwell. Some people will cough up all the time, and sometimes it is just a small amount, or other people will cough up a lot more. And also the color can vary. So this is a chart of all the different sputum colors on the left-hand side here, varying from clear all the way up to green. Other symptoms include breathlessness, so feeling short of breath and difficulty breathing, also tiredness or fatigue. Because the airways, the lungs and the upper airways and the nose are all one compartment, people can often have problems with their sinuses also, and have infections in their sinuses or inflammation in the sinuses, the same as in the lung, because it is all one compartment. People can have cough incontinence and bladder leakage, anxieties and depressions associated with bronchiectasis, and then much more rarely, occasionally someone can have coughing up of blood and also chest pain. How is it diagnosed? To identify that someone has the widening of the airways that are bronchiectasis, we usually do a CT scan. And this is a picture of your lungs on a CT scan here. And on the scan, you can see the widening of the airways, and you can sometimes see airways which are blocked with mucus and plugged. It's also likely that you will have had a number of tests when you got your diagnosis, lung function and breathing tests to look at how the lungs are working. And then also sputum tests. We are asked to cough sputum into a pot to look for different infections that may be treatable. And then also blood tests for general health, and also to look for different causes of the condition. So this next part is the first quiz in my talk. I just wanted to know what people think the main cause of bronchiectasis in Europe is. I don't know if I launch a poll or if someone does it for me. Anyone able to launch my poll? Oh, here we go. So what are the most commonly reported causes of bronchiectasis in Europe? Is it having had bronchiectasis after an infection, such as an infection in childhood where the lung is left with a vulnerability? Is it due to genetics and conditions that are inherited? Is it due to smoking? Or do we not know? I'll just give you a few seconds to fill out that. Okay, shall we move on? Have we got the results? Oh, there we go, quite divided. So the most important thing is to say that it is not usually related to smoking at all. And that is a very common misconception that, that some doctors have. And it's important that we get rid of that misconception that bronchiectasis is not because of smoking. In a small number of people, it is because of genetics, also infection, but in the majority of people who get bronchiectasis, we often don't know what the cause is. So if I move on, and here is just a list here of all the other causes and all the other reasons that people can develop bronchiectasis. So problems with the immune system, so that the immune system is not so good at fighting chest infections. Sometimes it's associated with inflammatory bowel disease or IBS. Some people with COPD or asthma or other lung diseases can also develop bronchiectasis, and that can complicate that other condition. Some people have a severe allergic response to a fungus or a mold called Aspergillus, and that can cause bronchiectasis. And then much more rarely, it can be associated with reflux, or sometimes with inhaling a foreign object, so something like a nut, and that blocking the airways. So the most important thing to take away from this, I think, is that bronchiectasis is not the same for everybody. So symptoms can be very different, and also the cause or the reason that people develop this widening of the airways can also be very different from person to person. And now I'm a scientist at the University of Dundee, and I'm now just going to take you through a little bit more looking under the microscope at what is happening in the lungs of someone with bronchiectasis. And currently, the way we sort of understand what's going on in the airways is with this vicious vortex model, it's called, essentially with the 4 components of what happens in bronchiectasis. And I'm going to take you through them one at a time, starting with the thing that I'm most enthusiastic about, which is the cilia. So the cilia, in each of your airways, you have a number of cells, and on each of these cells, they have little tiny hair-like structures. And the job of those hair-like structures is to move in a coordinated way and clear secretions and clear things out of the airways. And they're the first point of defense of your airways against breathing in things like pollutants and bacteria and virus. And what they do is they take those things and they waft them back out again whilst they're in the mucus. And you can sort of see in this video, so this is a video of some cilia moving and clearing things out of the airways. This is under a microscope, so in real life they are thousandths of a millimeter. They're very, very tiny, and they're also much faster than this, but this is zoomed in on a microscope on the inside of your lungs. And what they do is they clear and they move things out of the airway and keep them clean. This is a video from someone with bronchiectasis compared to that healthy volunteer without bronchiectasis that I just showed you. And you can see that these little cilia are much slower, they're clogged up in mucus, and they're much less able to clear the airways and keep them clean. And we're going to hear a little bit more about if your cilia don't work, or if you've got a lot of mucus and you have bronchiectasis. We're going to hear at 12 o'clock UK time or 1 o'clock European time about physiotherapy and airway clearance from Arietta Spinu. And the best thing you can do if your little cilia aren't working and you have lots of mucus in your airways is to do airway clearance techniques to do that job for them so that your airways can stay clean and clear. So in bronchiectasis, you tend to have excess mucus, and that affects these little cilia and stops them working properly. And as a result of that, lost my moving slides on a bit. Here we go. As a result of that, you end up with mucus accumulating in the lungs, and in that nice, thick, sticky mucus, you get bacteria and bugs. So this is another microscope picture zooming in on some phlegm. This is a black and white picture, but sort of imagine this as being sort of yellowy green phlegm. And each of these dark little dots is a bacterium. So essentially, bacteria love to live in phlegm because it's warm and it's moist and it's sugary. And so if you don't clear that out of your airways, then they can get in there and they can live in there. And a lot of the causes so a lot of the things we do to try and treat bronchiectasis are antibiotics, and that's to clear these bacteria out of the lungs with short courses for exacerbations, but sometimes also inhaled antibiotics to try and get straight to the source of where the infections and the bacteria are. And one particularly problematic bacterium in bronchiectasis is one called Pseudomonas aeruginosa. And Pseudomonas can grow in sputum, and it particularly likes sputum. And once it's in there, they can all clump together. So that each one of these is one bacteria, and this is very zoomed in, and they have little tails, but they can all clump together, and that makes them even more difficult for the antibiotics to kill in what is called a biofilm. So we're going to hear a little bit more about Pseudomonas in the sputum this afternoon from Yoshi, and then we're also going to hear a bit more about antibiotic use and home IVs from Tanya in a patient video later on in the conference. When you get an increase in the number of bacteria or a new bacteria or some sort of some other sort of event, then quite often people can have chest infections or flare-ups, or what we call exacerbations. And you'll probably hear people talk about exacerbations a lot today in their talks. For just like the symptoms are different for everybody and the causes are different for everybody, exacerbations can be very different for everybody who has bronchiectasis. But we actually have a definition that we use for things like clinical trials. And that definition says that an exacerbation is to have a deterioration in 3 of the following symptoms, and that is cough, so an increased cough, an increased sputum volume or consistency, a changing color of your sputum, so moving to greener, breathlessness, or a lack of ability to do so much and be able to exercise so much, increase in tiredness, and then sometimes coughing up blood. And if you have an exacerbation, often it will be treated by antibiotics. I just wanted to show you this interesting research here from during COVID, because we've learned during COVID that actually viruses are also very important in exacerbations. So this graph shows you the number of people here in Tayside, where I work, who had exacerbations of bronchiectasis for each year. So 2018 to 2019 is before the pandemic, and you can see that the number of people who had no exacerbations, or the percentage of people that had no exacerbations, was here about 30%. And the same in 2019, before the pandemic, about 30%. And then we had a lockdown in the UK. Everyone started wearing masks. People were socializing less. We had there was an increase in hand hygiene, and there were a lot less virus about. And actually, the number of people that had no exacerbations then went up to about 80%. So we've learned from the pandemic that actually viruses as well as bacteria are very important in exacerbations of bronchiectasis. And Lucy's going to talk about that a little bit after me today. So the final part of that circle of things is inflammation. And we know that in a healthy lung, if you have some bacteria in the lung, then the body will recruit lots of cells from the blood system to come and clear that infection and get rid of it. And one of the cells that it recruits is a cell called a neutrophil, and they look a bit like this under the microscope. And I've got a video here of what a neutrophil does. So this cell here is the neutrophil. These little green things here are bacteria. This is from YouTube, but hopefully it will work. So what the neutrophil will do is it will come in and it will gobble up the bacteria and get rid of it and digest it, basically. So that's what would happen in a healthy lung. In bronchiectasis, because there's a lot of sputum and there are a lot of bacteria hanging around all of the time, then you get lots and lots of neutrophils that get recruited into the airway, and then they basically don't successfully clear those bacteria, so they recruit more and more and more, and then instead of killing the bacteria and moving on, they can get old and they can perform differently to your neutrophils or your immune cells would usually perform. And quite often something that they will do is explode, and in what is called a neutrophil extracellular trap. So they explode and all of their contents spills everywhere. And the contents of these white cells can actually be not that good for you. So they've got things that will digest the bacteria. So they've got lots of proteins in there that then can damage the lung further. And Professor Chalmers is going to talk later on about new treatments for bronchiectasis. And I suspect he will talk a little bit about addressing the way that these neutrophils work. So in summary, bronchiectasis is the widening of the airways. Symptoms are mainly cough, sputum, and repeated chest infections, but can affect people very differently. Exacerbations or flare-ups are an increase in cough, an increase in sputum volume, and a change in colour. And the cause or the reason that bronchiectasis continues and affects people involves this cycle of events with cilia not working, bacteria getting into the lung and infecting it, doing damage to the structure, and then all of these neutrophils coming in and causing inflammation. So I hope that was an okay overview of what we're going to talk about today for the rest of the conference, and I hope you enjoy the conference.
Thank you, Amelia, for your interesting talk. I hope you can all hear me now. There were some problems before. I'd now like to introduce clinical professor Lucy Morgan. She's a lung specialist from Sydney, Australia, and also chair of the Lung Foundation Australia. Please go ahead, Lucy.
Thank you so much for having me. Thank you for that lovely introduction. I hope all the mothers online or those in the UK are having a happy Mother's Day. It's dinner time here, it's nighttime here in Sydney, but I'm very, very thrilled to be included in this international conference. So I'm Lucy and I'm a lung doctor working here in Sydney. And as I was just mentioned, I'm also chair of Lung Foundation Australia, which is a bit like the European Lung Foundation. And I'm the chair of the Australian Bronchiectasis Registry, which is our version of EMBARC. So I'm going to share some, I'm hoping that somebody will put my slides up for me, please. No?
Just allow me 1 moment. Sorry.
Oh, I'm so sorry. I was just making sure I wasn't supposed to put them up. So while my slides are coming, I'm going to share some introductory ideas about viruses and the impact that they might have on patients with bronchiectasis, as well as some ideas about how they might actually contribute to the cause of bronchiectasis. So it's trying to sort out a little bit about what's chicken and what's egg. Thank you. Thanks so much. So I work in Sydney, and that's the view out of my office window down the bottom there. I'm a professor at the University of Sydney, and I'd love to welcome any of you to come and visit us sometime now that the borders are open. Next slide, please. So I'm going to give an overview, just an overview, an introductory walk through some of the issues around how viruses, particularly respiratory viruses, do what they have evolved to do. How is it that they get into our bodies and replicate and then we spread them around? How is it that respiratory viruses cause bronchiectasis? How might respiratory viruses make bronchiectasis worse? And some ideas about what we can do to protect ourselves from respiratory viruses. Can I have my next slide, please? Okay, so the word virus is Latin for poison. And it's not hard to work out why. I mean, I think anybody who's ever had a nasty flu-like illness being poisoned is exactly how you feel. No wonder people, I guess slightly, people in generations past who couldn't see these viruses under electron microscopes, it's no wonder they thought that there might have been some poison put in the water or in the wine. So how do viruses get into our lungs and poison us? Can I have my next slide, please? So respiratory viruses are spread and received, infected via the respiratory tract. So the respiratory viruses get into the lungs and they're inhaled. And this is one of the situations in life where size really does matter. So big particles, big droplets, whether there's virus in them or not, are always trapped by the nose, by the little hairs in our nose, by the cilia, and by the mucus that's in our oropharynx. Sometimes we breathe them in through an open mouth, but they'll still be trapped in the upper airway. But the very tiniest of particles will travel right down the major airways into the smaller airways, and will be able to deposit themselves right down deep in the very tiniest of airways. So if it's a bit of snot, a fomite, that will be a big droplet and it'll drop onto a surface. And those are the sorts of viruses that, there are viruses that like to travel in fomites, and those are the sorts of viruses that we spread by touching something where there's a bit of muck on the surface, be that a handle of a door handle or a kitchen bench or a tap. And then we touch our eyes or our mouths and the viruses get in that way. This is the way that many enteroviruses or tummy bugs viruses are spread. But the respiratory viruses tend to be inhaled, and those in tiny, tiny droplets make their way down deep into the lungs. Can I have my next slide, please? Once the virus, which is in a picture in the top right-hand corner of this slide, I often think these viruses remind me of those Ferrero Rocher chocolates. They've got a shell with little lumpy bits, and those are the spikes that allow the virus to attach to cells. And inside the shell, just like in a Ferrero Rocher, there's a tangle of nucleic acids, so a tangle of genetic information that allows the cell to, the virus to replicate. So what these respiratory viruses do is attach themselves to the lining cells of our airways. And they've all got various different receptors that allow them to attach to different spots. Different cells, different receptors on the airways. Once they've attached, they basically get themselves into that cell, and sometimes they're swallowed by the cell and sometimes they merge their way in. Once they're inside, the inside nucleic acid unravels and allows the cell to replicate inside the cell. And once that happens, the host cell is usually not feeling very well itself. There's often damage done to that cell, and it doesn't function very well and starts to release the soup of chemicals that Amelia was just talking about. We call those cytokines. And all of those cells, all of those chemicals that are released from a cell that's not feeling very well are also damaging to cells around it. Once that virus has replicated, and there are lots of baby viruses in there, they are released and the host cell actually dies. And it's the dead host cell that often contributes much to the purulent or mucky sputum that we cough up. That's a lot of that is dead cells. But there are also lots and lots of cytokines or chemicals that are released from that dead cell that cause other damaged tissue. Once the new virus is there, they scoot around and bind to other cells and can actually make their way into our bloodstream. That's a simplistic view, but it's just a way of understanding why it is that something that you breathe in can manage to get into the bloodstream and make us feel so very poisoned. Next slide, please. Oh, okay, this is not projected very well. I'm sorry, this is a bit blurred. It's really just a reminder of, so you can go back and have a look at the original slide. There is, I think, a website on the top of this, but this is our most famous, and I think this is the real bad guy of respiratory viruses for our generation. And this just explains why it is that some people get a very, very mild illness, but some people get a very, very severe illness with COVID-19. I might just keep going because I think you guys all know about COVID-19, but viruses can actually cause bronchiectasis. So a severe viral illness at any age, whether it's a newborn baby, a little toddler, a school-age child, a teenager, a young adult, or an older adult, even whether they've had that, whether they've had any underlying lung disease or not. A severe viral illness can be the beginning of the damage that occurs that leads to bronchiectasis. So this is another version of the vicious cycle that Amelia presented in her talk. If there's a significant infection, this can lead to inflammation in the airways, the release of the cytokines and the neutrophil enzymes and the bacterial products that we've been talking about, a whole lot of poisonous chemicals. These chemicals themselves cause other tissue damage. They're particularly good at turning off our normal protective mechanisms, including things like mucociliary clearance. So the way that the respiratory cilia sweep and clean the airways of the mucus and cellular debris. So if they turn off that protective escalator, then muck and dust and dirt and bacterial and viral products and inflammatory products that are there in the airway cannot be cleared. Once there's all this inflammation going on, there is airway mucus hypersecretion. So that means lots more secretion than would be normal. And that mucus itself is much thicker and much muckier than it would be normally. It's got lots of poisonous cells in it. Once that occurs, the cycle of lots of bacteria moving in and ongoing colonization, or it's a bit like people, squatters moving in and trashing the joint. And then once that happens, we've got a cycle of airway stretching and airway inflammation and airway damage that then ends up leading to the bronchiectasis. Now, there are some specific viruses that are more likely to cause this than others. So usually a common cold causes a sore throat, a runny nose and snuffly upper airway. There might be a bit of headache, but it's the severe viral illnesses such as influenza, the coronaviruses, respiratory syncytial virus and measles virus, as well as adenovirus. These are just the names of the viruses that are particularly likely to cause a very systemic illness. So lots and lots of high fever, shivers and shakes, muscle aches and pains. And these are the ones that like to get into the small airways and set off this very, very vicious cycle. Next slide, please. So bronchiectasis itself, of course, is Greek. We've had a Latin word in virus being poison, but bronchiectasis comes from the Greek. Bronchi meaning airway, ektasis being dilatation or stretching. So it's the process by which normal airways that might be aligned to normal airways in spongy lung that might be a bit like a loaf of fresh bread, as you can see here, becoming so damaged by the vicious cycle that the lung becomes a bit more like a crumpet, which you can see here. Now, I'm sure it's not just in England that you'll know about crumpets, but you can see instead of being soft and fluffy and squishy with tiny tapering airways that would be almost invisible at the very edges, we've got a spongy lung that has become stiff and a bit fibrous and a bit rubbery, and where the airways are much bigger than they should be and have the potential to be filled up with secretions and become the cause and to cause cough. Can I have my next slide, please? So it might be stretching things a little bit, but if you look at this CT scan, and if you think about this scan Amelia showed, but this is a cut through the lungs at around about the level of the heart, because you can see the left lung and the right lung, and then the heart there in the middle. If you squint a little bit, you might be able to convince yourselves that these holes here, which are in fact dilated airways, do look a little bit like a slice through that crumpet that I was showing you. Okay, next slide, please. So when you develop crumpety lung or some bronchiectasis, you can understand why you might be a bit breathless, because you've got holes where you used to have spongy lung, and why you might have cough. But if your crumpet is dry, like this one, and it doesn't have butter and honey poured on it, then you might have a cough that might be a dry cough. It's not until you put butter and honey or custard or mucus and secretions into those airways, that it really becomes a productive cough. But of course, because of the inflammatory process and the cycle that we've been referring to, it's very, very unusual that you'll have a lung that looks like this dry crumpet. Next slide, please. What's much more likely is that it'll be a crumpet that's got some muck in the airways. So when, what was I going to say about that? So I think that's probably enough about how viruses can cause bronchiectasis, but all of the people, all of you will be really familiar with the concept of a bronchiectasis flare-up or an exacerbation. And I think Amelia's already told us a bit about how often viruses are actually the trigger to making bronchiectasis worse for anybody who already has bronchiectasis. So viruses, whether we've got bronchiectasis or not, make us feel sick. Some viruses make us feel very, very unwell. So a minor head cold might be just that: sore throat, runny nose, stuffy head for a few days. But a severe flu-like illness, whether it's from influenza or a COVID infection, COVID-19 infection, can make us feel systemically very, very unwell. Once there's been a virus in the airways, it's very likely that there'll be a secondary bacterial infection. And I think we're going to talk a bit more about that later in the day too. Most viruses have the capacity to trigger an exacerbation of bronchiectasis. Although, as I said in my last slide, it's only some viruses that really are really likely to cause the bronchiectasis in the first place. But even a common cold can trigger an exacerbation if there's bronchiectasis already there. And bronchiectasis exacerbations or flare-ups are really bad. We all know that. You feel sick at the time, you need more treatment at the time. Sometimes it's bad enough to need hospital. Bad things happen in hospitals, and lots of exacerbations are very, very bad for all of us. So even the mildest of viral illness can be associated with a very, very bad outcome if you've got bronchiectasis. Next slide, please. I think you just spoiled my punchline, because this is what an exacerbation looks like. If I put you off your crumpets in my first slide, these are slides of crumpets spread with guacamole done on my kitchen bench. So I didn't make my children eat them, don't worry. But a crumpet that is filled with chronically infected or sputum colonized with organisms, of course, is going to be very purulent. It's going to be mucky. There's going to be more of it, and so it's going to lead to an increase in sputum production, fatigue and malaise, feeling very tired and weak because you've got chronic infection in your airways. There may be fever if you have an exacerbation that's triggered by a viral illness, or even by a bacterial exacerbation. So this is the analogy of if dry crumpet is bronchiectasis without sputum in it, I think you can see why I might call an exacerbation a mucky crumpet. Next slide, please. And of course, sometimes it's not only a mucky crumpet, but there's hemoptysis or blood streaking in the sputum, so blood streaked sputum. And some poor people, some patients are unlucky enough to have a flare-up of symptoms that leads to bright or frank hemoptysis, which is bright blood being coughed up. So this is where I know I'm stretching my analogy and my friendship a bit, but we think about a bloody mucky crumpet. Okay, next slide, please. Okay, I'm changing tack a tiny bit here, and I don't want in any way to be flippant, but I think this slide is my opportunity to recognise that some really very, very difficult things happening in our world at the moment, and I'd like to take the opportunity to recognise the difficult time for the people of Ukraine, and also to note my gratitude from this side of the world to everybody who's supporting these people. But I think I'd like to stretch my analogies a little bit further to think about an invasion as being a bit like having a viral illness to a person who has bronchiectasis. We can't always avoid invasions, but if we notice warning signs, if we understand the risks, we can perhaps be a bit better prepared. And I'm sorry, I'm being slow, so could you please move to my next slide, please? What can we do to protect our borders from invasion? Amelia showed us just the power of the tactics of COVID avoidance, of being able to be physically distanced from other people who might have the virus, about wearing masks, about being prepared, about bolstering the battlements and having a battle plan. I think these are all things we can do, and I'm going to talk about that briefly in the next slide. Next slide, please. So we can avoid viruses to some degree. Wearing masks properly, unlike this deer poppet in California in the Spanish flu. Wearing masks properly does certainly reduce both the inhalation of virus particles and the spreading of virus particles. Hand washing, standing further apart than this group of family, being in the fresh air and staying away from those who have an active viral illness are all ways to reduce your risk of becoming infected. Next slide, please. You can protect yourself from enemy attack. So vaccinations are particularly important, and you know, having enough vaccinations for the particular virus you're trying to protect yourself from can certainly reduce severe illness and death. This is particularly true of influenza and COVID-19, and we've seen great evidence of how very effective enough vaccination can be. Unfortunately, there are some viruses that do make us very sick from a respiratory point of view, for which we have no vaccines, and these include the common cold and RSV virus, which is particularly potent for very elderly patients and for those who are very, very young. Next slide, please. So we can also bolster our battlements. These are ways of protecting ourselves from the terrible effects of invasion. So keeping yourself fit when you're a patient with bronchiectasis is a very, very important way of bolstering your battlements. Keeping your airways as clear as possible, making sure you have enough of your own medications, all the sorts of things that you might find if you had a stepwise management of stable bronchiectasis, such as the one I've demonstrated here, which we have made for the Lung Foundation of Australia. I know you'll all have your own local documents, but it's a way of making sure you and the clinicians who help to care for you understand what you need to keep yourself well when you're stable. Next slide, please. So the last slide is really about having an early tactical response to invasion. So this is, instead of just knowing about what you need to do to keep yourself well on a normal day, know what you're going to do when you get a virus. So this is the Australian version of this kind of battle plan. This is a bronchiectasis exacerbation plan. So this allows you to just a reference guide to help you, and often your clinicians, to recognize that your day-to-day symptoms have got worse, and this is in fact a flare-up or an exacerbation. So if you've got a viral illness, you do need to treat those viral symptoms just so you feel better. Things like pain relief, drinking enough, keeping yourself warm, and lashings of what we call TLC or tender loving care are very, very important just to help you feel a little weller when you're getting over the virus. But then, of course, there's the need to treat the exacerbation, and this often involves antibiotics, and it often involves an augmentation or an increase in the frequency of your airway clearance mechanisms. Sometimes it will mean needing another medication on top, such as steroids, but it's going to depend entirely on you and your bronchiectasis. But it's always worth having a bronchiectasis exacerbation management plan already made so that you can act quickly if you do get an exacerbation. Next slide, please. So that's the end of my presentation. I'm sorry I was a little bit slow. I'm hoping that you'll have taken away some understanding that the way respiratory viruses are designed is to invade a mammal, to replicate inside their cells, and then to disseminate or spread to other organisms, to other mammals. I hope you understand that respiratory viruses can both cause bronchiectasis by tissue damage and inflammation as a trigger to the vicious cycle hypothesis of how bronchiectasis develops. But viruses, when they get into the bodies of people who already have bronchiectasis, can induce exacerbations. And that there are some things we can do to protect ourselves from the damage done by respiratory viruses, by investing in our in defense and in our battle plans. Next slide, please. Thank you very much. This is a picture I took on holidays before the pandemic, and it's just to remind us that there's value and virtue in going to beautiful places with people we love, in the boat built by my husband. Thank you very much.
Thank you so much, Lucy. For this great overview. I saw several questions for you in the chat, and we might end up discussing this in a few minutes. Now it's my turn, and my task would be to give you all a general overview of treatments for bronchiectasis. Someone can give me a green light if they are seeing my slides.
Yep.
Yeah, very good. So the first important issue here is that what we are asked to understand as a physician is the complexity that each single patient with bronchiectasis has. And this is mainly because there might be different and multiple symptoms. We hear about cough, sputum production, fatigue, hemoptysis. There are people that are complaining for dyspnea, chest pain, or even weight loss. And each single patient has also different and multiple objectives. There is a priority for improving symptoms. For someone, there is a priority in terms of reducing exacerbations or even hospitalization, increase exercise capacity, and the majority of our patients want to increase their quality of life. This is important because we have specific tasks when we want to build the right individualized treatment program together with our patient. So the first thing is we are supposed to understand each single patient's needs, concerns, and goals. Every time we see the patient in the clinic, because needs, concerns, and goals can also change over time. And we are supposed to do with a patient a sort of priority list of different goals, what we want to obtain, when, and how. And to me, it's also very important to have a caregiver or a support person in the clinic with our patient, because there are some very important decisions. And I'm thinking about long-term treatment for non-tuberculous mycobacteria, for example, that we need to share also with a caregiver. So the treatment approach I would like to share with you today is mainly based on patient priorities. So the first thing that we need to check is about smoking status and avoiding sedentarisms. So we always have in mind different lifestyle changes, smoking cessation and referral to dedicated centers. And please go on the European Lung Foundation website and get very useful information about smoking. It's always important increasing the exercise capacity for some people with bronchiectasis. And in this case, the multidisciplinary approach have also the GP, the general practitioner, dedicated physicians for smoking cessation and physicians working in rehabilitation centers that are working with us as a pulmonologist in the program. The second thing I tend to look in my patient is before going into the lung and into the problem of bronchiectasis is being sure that comorbidities are optimized, are recognized, and their management is optimized. There are plenty of comorbidities for each different patients. There are cardiovascular comorbidities, there are gastroenteric comorbidities, like gastroesophageal reflux disease or inflammatory bowel disease. So this is one of the fields where we need a large help from different colleagues, including cardiologists, immunologists, rheumatologists, endocrinologists, and also psychologists and psychiatrics. We will have in few hours a lecture about anxiety and depression that are a relevant comorbidity in patients with bronchiectasis. The third thing is to treat mucus hypersecretions and mucus plugging. And respiratory physiotherapy, we know, is the main intervention in people with bronchiectasis. This is a nice figure we took from the latest European Respiratory Society guidelines on the management of adults with bronchiectasis. And as you can see, mucus problems are there, and there are plenty of individualized treatment to help people to clear their lung. And in this case, respiratory physiotherapists are crucial healthcare professional that are working with us every day in trying to teach people how to clear the mucus and breathe properly. Another topic is the use of long-term mucoactive treatment, like hypertonic saline and acetylcysteine, sorry about that, mannitol, and other cysteine derivatives. If we take a look at the guidelines of the European Respiratory Society, the long-term mucoactive treatment is suggesting in bronchiectasis patients who have difficulty in expectorating sputum with a poor quality of life and where standard airway clearance techniques failed to control symptoms. In this case, respiratory physiotherapists are still there, and the help of the GP is very, very important. Another important trait that we tend to look in our bronchiectasis patients is the impact of infection. And I think that one of the most important intervention, as Professor Morgan said, is be sure that our patients are vaccinated against influenza, against the pneumococcus, against the SARS-CoV-2, and for some patients also against Haemophilus influenzae. Besides these four kinds of vaccinations, we always need to think about all the other vaccinations that our patients with bronchiectasis are supposed to get according to their age and their risk factors. And in this case, we have help from the general practitioner. Talking about infection, one of the interesting and most relevant intervention the majority of us is proposing to our patients is the eradication of Pseudomonas. At the first or new isolation of Pseudomonas, there might be the possibility to suggest patients to underwent a treatment with oral and or inhaled antibiotics to try to eradicate Pseudomonas. There are several approaches that all of us are suggesting to our patients. There are no clear data about that, but looking at the data from real life studies, there are bronchiectasis centers that are suggesting the eradication of Pseudomonas because these might reduce the coronary forming unit of Pseudomonas and might improve patient symptoms. There are two difficult to treat pathogens. One is Aspergillus, because Aspergillus has a great diversity of clinical and radiological manifestation. like ABPA, which is allergic bronchopulmonary aspergillosis, with specific treatments like aspergilloma, which is a possible radiological manifestation in people with bronchiectasis, and several other diseases. And we also know about the role of non-tuberculous mycobacteria. If you have the chance to take a look at this interesting survey that Michael Steinberg and colleagues published in the European Respiratory Journal Open Research recently, you can see that patients has different concerns about this disease. A disease that deserves a long duration of treatment with some side effects, and that usually is treated in a specific NTM referral center. In this case, clinical microbiologist is really, really important in the multidisciplinary team, especially for the identification of the pathogen. Another treatment we have to combat infection is the long-term inhaled antibiotics treatment. This is a recent systematic review showing a clear role of long-term inhaled antibiotics in reducing exacerbations, although the data are really heterogeneous. And the guidelines are suggesting to consider long-term inhaled antibiotics in bronchiectasis patients who are frequent exacerbators, 3 or more exacerbations per year. Especially if they have a chronic Pseudomonas infection, in case the oral antibiotic prophylaxis is contraindicated, not tolerated, or ineffective in people who have a chronic infection different from Pseudomonas aeruginosa. And finally, we move to inflammation. Inflammation is another target for our treatment. We tend to understand, and we might have in the next future, important biomarkers already available in our clinical practice to understand how much our patients are inflamed and which kind of inflammation our patients have. In this case, we tend to use drugs like macrolide, like, for example, azithromycin, for several months. We have strong data that macrolides can reduce by 50% the exacerbation frequency in our patients. And this is also the case of patients who are chronically infected with Pseudomonas aeruginosa. In this case, we might need the help of different physicians, like the cardiologist, because macrolide might have some impact on our heart, clinical microbiologist to better understand the chronic infection of our patients. There might be some problem with the GI tract, so we might want to involve a gastroenterologist, and there might be some hearing problems where our ENT doctor is crucial. There are no other, there is no indication to use inhaled corticosteroids or even oral corticosteroids to treat inflammation in patients with bronchiectasis, beside specific situation and comorbidities I'm going to tackle in a while. And I think that Professor James Chalmers in few hours will talk about new anti-inflammatory drugs that show very interesting results a few months ago. Another trait is the airway obstruction and the role of long-acting bronchodilators. So routinely, we do not suggest long-acting bronchodilators for all the patients with bronchiectasis. We consider this for those with a significant shortness of breath, for those with a diagnosis of asthma or COPD, where there is a clear indication for these drugs. And we can use bronchodilators before physiotherapy or before inhaled antibiotics in order to improve the tolerability of these drugs. In this case, respiratory physiotherapist has a special role to teach patients together with a pulmonologist and to follow up compliance and the use of these drugs. In terms of comorbidities, asthma and the BPA deserve a special treatment, and with bronchial hyperreactivity, here there might be, there is a specific rule for inhaled corticosteroids. When people deserve to get inhaled corticosteroids because they have asthma, because they have COPD, or because they have ABPA. Within the treatment overview, one of the goals would be to take bronchiectasis out. And it's important to have clear in mind that there also be a surgical option. The surgery is indicated for people who have localized bronchiectasis, when we know that bronchiectasis are not due to the most common genetic diseases causing bronchiectasis, that these bronchiectasis are not progressive, and that the patient has a significant impact on his quality of life, also in terms of frequent exacerbation, although respiratory physiotherapy and the medical treatment are optimized. And in this case, we share the management of our patients with the thoracic surgeon. Finally, just a slide to remind that there are several other crucial interventions like rehabilitation. In people who develop chronic respiratory failure, the proper use of long-term oxygen therapy and non-invasive ventilation is really, really important. For patients with hemoptysis, with a strong history of hemoptysis that cannot be managed through respiratory physiotherapy and medical treatment, embolization is an option. And finally, we also have lung transplantation for very small percentage of our patient. And in this case, there are people and colleagues like the interventional radiologist and again the thoracic surgeons helping them to manage properly the patient. This is my last slide, and during the pact between the physician and the patient in the management of bronchiectasis, there are something that a patient can do to help us to treat them and to manage them better. The first is to have a sort of priority list of symptoms, and what I can ask my patient is to detail changes of symptoms over time, because the patient can change in months or even years. I usually ask the patient to take a diary of her or his exacerbations. When the exacerbation started, how did it start, which symptoms have worsened and which have appeared for the first time, possible triggers, or medication that can or cannot help the patient to manage the exacerbation. And this is really helpful for us as a physician to better understand the treatment we can offer our patients. Similarly, for those who have a frequent episodes of hemoptysis, I tend to ask them to take a diary of these episodes. And I always ask people to have with them relevant documentation like chest CT scan, blood test, microbiological report in every time they come to the clinic, because as their situation is changing, also my intervention can change. So I need to reevaluate some documentation. And finally, this is the last but not least, because it's really important. Part of the treatment is related to compliance. So what we want is to have our patient reporting us about compliance to specific intervention. If they are not doing respiratory physiotherapy, why, when, and the triggers of this low compliance, because these are really important information for us to change and to treat them better. With this, I would like to thank all the friends in the ELF and in the EMBARC community for this great opportunity to talk this morning to all of you.
Thank you, Stefano, for your interesting talk. I think it's time to start the Q&A now. A lot of questions have already been answered in the background through all the physicians, but I think we can repeat some of the questions. So can you find the questions, Stefano?
Yes, absolutely. Let me. Okay, very good. I saw there are a couple of questions to our speaker, and I think we can start with Professor Morgan. Lucy, there was a question about the type of viruses that are triggering exacerbations in bronchiectasis, and one of the patients was asking about their names and prevalences. Do you have any insights for us about that?
I think the triggers for exacerbation, the commonest trigger for exacerbation of bronchiectasis would be the common cold in a normal year, when we weren't having a COVID pandemic. That's absolutely the commonest respiratory virus around, and it's absolutely the commonest cause of an exacerbation. The commonest causes of bronchiectasis are the less common in viruses, thank goodness, or else we'd all have it, I think. So the respiratory syncytial virus, RSV, is very common as a severe viral illness in very little babies and in very elderly people. But it doesn't seem to cause severe illness in older children or young adults. Doesn't mean that they don't get RSV, but they get more like a cold than a severe flu-like illness. And so it probably doesn't cause bronchiectasis to the same degree. Influenza is one of our most potent severe respiratory viral illnesses in a when we had outside of COVID-19. And every year across the world, thousands of people die of influenza illness. And those who don't die, many people have consequent lung problems, some of which is bronchiectasis. A severe bacterial pneumonia is a very common consequence of a severe influenza illness. And it's one of the reasons that vaccination is so important in order against influenza, to protect us against developing bronchiectasis, because it not only protects us from having the flu, but it protects us from getting the terrible post-influenza bacterial pneumonias that are so very pro-bronchiectogenic, I think that would be the word. So the answer is that the commonest viruses to cause exacerbations are the common cold virus, for which we have no vaccine at the moment and no really effective curative treatment.
Thank you, Lucy. There are some questions on the chat about eradication of Pseudomonas, and I can take this. The idea of eradicating Pseudomonas is something that we, as a bronchiectasiologist, have in mind since many years. The different approaches I showed in my slides are mainly based on expert opinion, because if you take a look at the literature, there are very little strong data from randomized controlled trials. However, in real life setting, there are some observational data that can tell us that these treatments are useful. We don't know for how many months or years, but if done properly in the right patients, we might have an improvement in signs and symptoms. So oral ciprofloxacin is one of the drugs that are in the different approaches suggested by the guidelines. There might be some intravenous antibiotics to be used, like ceftazidime, tobramycin, or piperacillin tazobactam, for example. And there might be, there is also a rule for inhaled antibiotics. So the sequential approach of oral or intravenous antibiotics with the inhaled antibiotics is based mainly on expert opinion and experiences that each single center has. And also the duration of treatment might be totally individualized on the severity of the disease and the clinical, radiological, and microbiological characteristics. So there could be an initial phase of 2 weeks, and then after these 2 weeks, there might be a continuation of inhaled antibiotics, or a new start of inhaled antibiotics, or even after 2 weeks treatment with IV drugs. So the eradication is completely individualized. This was one of the question. There was also a question for I think Amelia. I don't know if you had the chance to answer that. Was about the role of lymphocytes and neutrophils in the pathophysiology of bronchiectasis, I think. Have you had the chance to look at that question, Amelia?
Was that the question about macrophage monocytes?
Yeah.
Yeah, so there was a question in the chat about monocytes. So the main, monocytes turn to macrophages. They come out of the bloodstream, go into the lung. The main cell, or the main immune cell in bronchiectasis that we see in the sputum, is the neutrophil, which is the cell that I talked about. And we think that is probably the main cell that is causing the problems in bronchiectasis. Interestingly, if you look at the other immune cells, so macrophages make up a very small proportion, but we do also see eosinophils, which is a cell that you traditionally associate with inflammation in asthma and allergic airway disease. And we have recently done some research where we've shown that about 30% of people with bronchiectasis will also have more eosinophils than you would usually see in the airways. So although neutrophil is the main cell we think about when we think about immune cells in bronchiectasis, also eosinophils might have a role. And again, I don't know if Professor Chalmers will maybe talk about that a little bit later when he talks about new therapies, because that might be, again, something that we are able to target.
Thank you, Amelia. And then there are some questions about treatment of the etiology of bronchiectasis. I saw Dr. Cumming answering about the role of immunoglobulins. So I didn't mention this in my presentation. I had a talk about that last year, but the management of the identification of the etiology of bronchiectasis and the proper management of treatable etiologies is crucial. And immunoglobulins are one of the treatment we have for people with common variable immunodeficiency, for example. But there are many other etiologies that deserve a special referral. I'm thinking about genetic disease, for example, and a special treatment. So I was more focused on common daily treatment, but of course, treatment of the etiology is crucial. As is crucial, the treatment of exacerbation. I didn't have the chance to show these slides, but maybe now it's important. The treatment of exacerbation is crucial. The recognition of the exacerbation. And please remember that we know that each patient has his own way to exacerbate. So our task is also to understand what an exacerbation is for each single patient. And for treatment of exacerbation, always we tend to look at the last antibiogram. So this is the reason why I mentioned that it's really important to have some microbiological documentation. And one of the most common questions is about how long should an exacerbation be treated with antibiotics? And this is an answer by the European Respiratory Society guidelines, suggesting that an acute exacerbation of bronchiectasis should be treated with 14 days of antibiotics. Of course, very low quality of evidence. It's a conditional recommendation. We need more data, but this is what we are doing in the majority of the bronchiectasis center. there was a very tricky question for you, Lucy, about the use of antibiotics to treat viral infection. Can you talk a little bit about that?
Certainly. Thanks, Stefano. My point was perhaps not clearly enough made. For patients who have no underlying lung disease, there is no use for antibiotics when there's clearly a viral illness. Antibiotics do not kill viruses. They only have an effect on bacteria. It's quite a different story when we're talking about patients who've got chronic lung disease, particularly patients with established bronchiectasis. Because as Amelia introduced and as Stefano has discussed, when there is abnormal airways and when there's lots of inflammation and abnormal mucus, then whatever it is that triggers an exacerbation or a flare-up of symptoms, and that might be a virus, the consequence is an increase in sputum, an increase in cough, and the treatment for the exacerbation for most patients with bronchiectasis will include some antibiotics to treat the flare-up of the underlying bacterial colonization that occurs. So the antibiotics are not to kill the virus. That's what the TLC and cups of tea and Panadol, paracetamol are all about in my treatment of my battle plan slide. So treating the virus is about supportive symptom management, but the treatment of an exacerbation of bronchiectasis, which was triggered by the virus, often includes antibacterial antibiotic treatment as part of the battle plan. I hope that's clearer.
Yeah, Annette, did you find any question you want to ask to our panel from your...
Yes, there was one question in relation to COVID. We're told Omicron is more mild in this case for those with bronchiectasis. Has there been any studies to provide data or case studies around the impact for those with bronchiectasis? I don't know who can answer this question, but
Look, I can just give some comments from my part of the world. In Australia now, with high rates of vaccine uptake, the Omicron variant has caused a large wave of infection, but most of those infections have been relatively mild, and our hospitalization rates have been much lower than they were for the Delta wave. For my patients with bronchiectasis, this has meant that, yes, they've had a flu-like illness. The symptoms have tended to be milder, and the exacerbations that have been triggered have mostly been milder as well. So yes, the viral illness has on the whole has been milder in a vaccinated population, and the exacerbations that have been triggered by this have been milder too. So that's in Australia. I'm sure it'll be different in all sorts of corners of the world.
Well, there is an important question about the role of inhaled corticosteroids in people without asthma and COPD or ABPA. And maybe I can take this because I mentioned this in my presentation. So inhaled corticosteroids are very, very, very important for people with a specific disease like asthma. It's the main treatment for asthma, and for these people should be there. There are people also with COPD that deserve inhaled corticosteroids, and corticosteroids we know are one of the first drug we use also in allergic bronchopulmonary aspergillosis. Outside of this indication, what we tend to do as a pulmonologist is to withdraw, to take the inhaled corticosteroids out from the treatment of our patients if there's no indication. And the reason why is because inhaled corticosteroids are a clearly recognized risk factors for difficult to treat infection like non-tuberculous mycobacteria, and can complicate the microbiome of our patients. And there are also data about in another disease like COPD, about the role of ICS and the possible occurrence of pneumonia. So this is what we tend to do with this drug. One more question for you, Lucy, and then we might want to close the session. It's about the timing between the virus entering the body and the start of signs and symptoms of exacerbation. One of the patients was asking about after how many days this can happen.
Thanks, Stefano. I don't think there's any magic number to that. I would say that the symptoms of the virus are pretty easy to track. They'll usually be sore throat, headache, runny nose, fever. And with coronavirus, that's going to include probably some muscle aches and pains, and there may be other symptoms. Often the exacerbation does not start at the same time as those viral symptoms start. It may be a couple of days later. So the first symptoms are almost certainly the viremia, the symptoms of the cold or flu-like illness, and the exacerbation usually lags a couple of days. I don't think there's any way of knowing which virus it is by the pattern or the tempo of the march of those symptoms, but there's usually a couple of days lag.
Thank you, Lucy. Annette, do you want to close the session?
Yes, I want to thank all the speakers for their talks and their enthusiasm for this day. I think we have a 15 minutes break now, and we hope to see you back soon. Thank you very much.
Thank you. Bye-bye.